Did you know that getting vaccinated doesn't make you safe from infection? One of the major reasons for this is that most infectious diseases move through populations by infecting those who are not immune to the disease and then spreading onwards. Those people who aid in the spread of the disease to you, someone who is vaccinated, are commonly referred to as vaccine hesitant. And while it hasn't been proven that vaccine hesitance causes the spread of disease, the goal of this research was to do so. Therefore, the research question that I present to you is, can influenza rates be attributed to vaccine hesitancy among specific populations? A current problem regarding this topic is that an increasing number of parents have concerns about vaccines for their children. In fact, US data shows a rise in the rate of vaccine exemptions for kindergartners, meaning less young children are getting vaccinated. In accordance with that, there's been an increase in the incidence of vaccine-preventable diseases. But what causes vaccine hesitancy? The 3 C's are some of the most common causes. The first cause of vaccine hesitancy is confidence. Oftentimes, people lack trust in the safety and effectiveness of a vaccine, causing them to be vaccine hesitant. The second C is called complacency, and that's a feeling that exists when one feels that the likeliness of them getting a disease is low, so there's really no need for them to get vaccinated. And the third and final cause of vaccine hesitancy is convenience. Many times people live too far away or don't have access to places where they can get vaccinated. Currently, vaccine myths are circulated by a variety of influential individuals. They're then read and repeated by parents and other media consumers. Influencers include doctors Andrew Wakefield, Robert Sears, Tony Bark, mommy bloggers Sarah Pope, Megan Heimer, Kate Tietche, and celebrity Jenny McCarthy. Many of these influencers rely on the media and the internet to get their message across. In fact, these influencers have over 7 million followers on Facebook, making them extremely powerful. And according to recent research, approximately 80% of people use the internet yearly in search of medical advice, and relatively few of those people ever discuss their findings with a healthcare professional. But what do these people who are vaccine hesitant argue? Many of them argue that vaccines are toxic and contain aluminum, antifreeze, ethyl mercury, and other dangerous chemicals that can lead to autism and various other health conditions. Others argue that a child's immune system is too weak and immature to handle vaccines, and that vaccines cause the immune system to become overwhelmed, leading to an assortment of health conditions. And finally, many vaccine-hesitant people argue that natural immunity is better, claiming that most vaccine-preventable diseases are harmless to children. However, while these arguments are understandable, they're not justifiable. Many of these arguments focus on areas of distrust in medical science. They advance the notion that vaccines are unavoidably dangerous because of toxins introduced into the body. Some of these chemicals, like aluminum, are present in some vaccines in small amounts. However, others, like antifreeze, are not and have never been present in vaccines. Ethyl mercury, another feared toxin, has been removed from most vaccines since 2001, despite any evidence of harm. Other arguments stem from areas of misinformation regarding the immune system and vaccine response. The argument that natural immunity is better completely ignores the fact that the body is already introduced to countless antigens from birth, and the relatively few antigens introduced via vaccines are negligible. However, researchers have documented an increase in the concerns of people about vaccines, which means more people are accepting these arguments. In fact, while in 2000, a survey was conducted and 19% of parents said they had concerns about vaccines for their children. However, in 2009, just 8 years later, up to 50% of parents answered as having concerns about vaccines. So, the goal of my research was to fill the gap in the current body of knowledge on this issue. I wanted to prove that people who are vaccine hesitant are responsible for the spread of disease, meaning that their reluctance to getting vaccinated directly affects the people around them. In order to do so, I would need to prove that a correlation exists between the levels of a certain disease in an area and the amount of vaccine-hesitant people in that area. So first I needed to figure out what disease I would study. And I quickly, after doing some research, I found that I would study influenza, also known as the flu. And that is because there was a ton of publicly available statistics on it, and it just made most sense for me to study it. Next, a little bit more difficult though, I need to figure out which groups of people are vaccine hesitant. Now, while brainstorming this, I quickly noted that these groups needed to be quantifiable. This way I can compare these numbers to the levels of influenza-like illness within each state. After doing some research, I found that typically education levels and financial status play a role when it comes to vaccine hesitance. I saw that people of lower financial status seem to be more vaccine hesitant, and that could be due to their lack of access to getting vaccines. Also, people who are less educated seem to be more vaccine hesitant, which could be due to their belief in the misconceptions out there on vaccines. However, I wanted one more variable to compare to the levels of influenza-like illness. So I began wondering which groups of people are vaccine hesitant, and I realized that I can go on the US Census Bureau and figure out the percentage of each state by race and ethnicity. And I wondered if that plays a part when it comes to vaccine hesitance. It could be due to religious affiliations or morals. Whatever it was, I just wanted to figure out if that plays a part when it comes to vaccine hesitance. And after going on the CDC website, I found that of the ages 18 and older, Hispanic populations have the least flu coverage at only 34.4%. Therefore, I chose to use the percentage of each state that is Hispanic as my third variable to compare to the levels of influenza-like illness. So, I decided to go with the correlational research method, as this was the best option for me. All of my information was already out there, publicly available, and my plan was to pull it all together and see if new correlations exist to find a new understanding. Now, this information that I needed to pull together was the state demographics, the levels of influenza-like illness within each state, the median annual household income, which represents financial status, and the average high school graduation rate per state, which would represent the education levels. So, this was the first place that I got my data from. This is the CDC website, and it contains an interactive map of the levels of influenza-like illness within each state. As you can see on the right, there's a scale from minimal to low to moderate to high. And I was able to note down each state's level of influenza-like illness. And I specifically took these levels from an earlier week on in the flu season. This way, at the end of my experiment, I would be able to compare it and see if the disease spread. Next, I used the Census Bureau to figure out the percentage of each state that is Hispanic, followed by the Census Bureau again to figure out the median annual household income per state. And finally, I used the governing database to figure out the high school graduation rates per state. After gathering all this information, I put it in a table and created 3 separate graphs to see if correlations exist between the 3 variables and the levels of influenza-like illness. I then went on Microsoft Excel and used the regression analysis tool in order to see what the p-value was. And a p-value less than 0.05 means that a correlation is statistically significant. So, this was my first graph that showed my results. This graph represents the relationship between the percentage of each state that is Hispanic and the levels of influenza-like illness in each state. As you can see, the scale on the bottom goes from 0 to 60. Ironically, 60 represents the lowest level of influenza-like illness, and 0 represents the highest level of influenza-like illness. And as you can see, there is a correlation that exists between the Hispanic percentage in each state and the levels of influenza-like illness. And this correlation is statistically significant, as the p-value is less than 0.05 at 0.019. Next, this graph represents the relationship between the median salary and the levels of influenza-like illness within each state. Again, you can see that a correlation does exist in support of my hypothesis, where the median annual household income was lower, the levels of influenza-like illness was also lower. And this p-value was 0.0425, which is just statistically significant. And finally, the relationship between graduation rates and the levels of influenza-like illness is represented in this third and final graph. And as you can see, there is a slight correlation between education and influenza-like illness. However, according to my regression analysis, this p-value is not less than 0.05, which means that it is not statistically significant. However, there is still a slight correlation. So, to conclude, I did not find a statistically significant correlation when it comes to graduation rates and levels of influenza-like illness, but it was a notable correlation. However, my other 2 variables did show statistically significant correlations. This means that where there were higher levels of influenza-like illness, there were also higher numbers of vaccine-hesitant people. But my one question was, did the disease even spread from those states? Because if it didn't, this would greatly weaken my findings. And as you can see by this map, which is a later week in the flu season, the disease spread catastrophically to almost the entire nation. So, what does this mean? I'm hoping that this can be implicated into society in several ways. First, I feel that doctors and other healthcare professionals can use this information as a tool to inform the public about the importance of getting vaccinated and the effect that vaccine hesitance has on not only yourself, but people around you. Furthermore, I feel that the use of PSAs can be implemented just to inform the general public. Because as I said earlier, many people don't even know why what reason there is to get vaccinated, and people lack trust in the safety and effectiveness of it. So I feel that it would definitely be beneficial to use PSAs in order to inform people why they should get vaccinated. And in the overall goal, this would hopefully lower vaccine hesitance and cause people to get vaccinated. I did face a couple limitations, the first one being that I did not represent every person who is vaccine hesitant. Not everyone who's vaccine hesitant is low financial class or didn't graduate high school, so I didn't cover everyone. And my second variable was that my second limitation was that not every variable was statistically significant. As I said, the graduation rates versus the levels of influenza-like illness did show a correlation, but it wasn't statistically significant, which does weaken my findings.
Thank you, Sean.
After you chose your research question, which information guided your choice of a research method?
Okay, so the information that I used to choose my research method was all about what I was going to be doing. And I knew that I was basically just taking bits and pieces of information from different databases and pulling it together to see if a new correlation exists. And those bits and pieces of information that I was pulling together include the levels of influenza-like illness, the state demographics, the median annual household income, and the high school graduation rates. And because I was pulling it all together in search of a correlation, I used a correlational research method, as that is exactly what I did.
What was the fundamental argument or idea in your research, and how does this argument and or idea relate to the primary purpose of your research?
So my fundamental argument was that vaccine hesitance causes the spread of disease. And this directly relates to my goal, which was to prove that my hypothesis of vaccine hesitance being the cause of the spread of disease to be true. So my goal future was to inform people through the use of PSAs and just showing them the correlations that I did find to exist, and hopefully get vaccine hesitance down and vaccine coverage up.
What unanticipated turn did you encounter as your research progressed? What were the reasons for this change, and how did you modify your method or approach?
So originally I was planning to research the causes of vaccine hesitancy. However, quickly I found that there were plenty of databases already talking about the causes of vaccine hesitancy, such as the 3 C's that I discussed. So I did want to present a new understanding rather than just supporting someone else's findings. So I just took it in a different way, and I stayed with the same topic, and I wanted to prove that vaccine hesitance causes the spread of disease. So I started just kind of going down that route, and that's it.
Okay, thank you.